Thank you everyone for joining. We're just going to give it a couple more minutes for Dr. Taylor and Tifa to make their way onto the Zoom and for anybody else who is planning on attending to get here. So we'll probably start around 3:05-ish, depending on when everyone else joins in. Hi, Dr. Tiford. Hi, Dr. Taylor.
Hello, hello. Good to see everybody, sort of. Yeah.
Likewise. I think we're just going to give it a few more minutes in case some people trickle in a little late. And then I think maybe 3:05 we can get started, if that's okay with you both.
Okay.
Perfect.
Your show. Let us know. There's a change of pace to be on this side of it. So this is great. Yeah. Love
Yeah.
it.
For us as well, it's kind of like, seeing the other side of things. It's gonna be interesting. It's gonna be fun.
Hey, you got a good audience. This is great.
I know. I'm very excited at the turnout. This is awesome. Thank you everyone for joining.
168.
Actually, I think we can get started now. If you guys think that's okay, just in the interest of time. I know it's a Friday. Don't want to keep anyone longer than we have to be. So first and foremost, thank you everyone for joining. I just want to take a moment to say thank you to Jack for presenting this idea last fall and getting a team together in the spring and making this happen. We've put a lot of work over the summer, so it's exciting to see all the turnout. I want to thank the rest of the Orthopaedic Journal Club as well for making this happen. And of course, last but certainly not least, Dr. Taylor and Dr. Tiford, we want to thank you both for being willing to be our faculty mentors for this and to really enhance our orthopedic knowledge and just our research skills in general. So without further ado, my name is Tariq Mukatash. If you don't know me, I'm a second-year comm student. And today we're going to talk about shoulder anatomy, a little basic review, and we're going to talk about pathologies of the shoulder. So our primary topic is going to be adhesive capsulitis, and we're going to touch a little bit about rotator cuff tears towards the end, just to segue into our proposed research project. And before I start, I just want to preface by saying I hope you guys learned something from this project, and I hope you guys are inspired to join the Orthopedic Surgery Club, a journal club, whether you're interested in surgery or not. No scientist is perfect, and we as physicians and scientists, we learn more from our mistakes than we do from when we're right. So this is not just something for you to be perfect and really understand literature right away. It's for you to improve your skills as physicians and to get feedback from two very renowned faculties in Dr. Taylor and Tiford, and to improve our skills in dissecting research and progressing literature forward. So I just want to give that little footnote, if you will. All right, so let's get started. So the objectives of today, we're going to review basic rotator cuff muscles and some shoulder anatomy. We're going to differentiate adhesive capsulitis from rotator cuff tear using history and physical exam. We're going to go over some diagnostic studies like ultrasound, MRI, when to order those for each case. We're going to review some treatment options, both non-operatively and surgical interventions. And I know OMS 2s who are on the call, we've learned about the shoulder already. I think OMS 1s, you guys are still in the thorax unit, but upper extremity will be your next unit. So hopefully this is a little foreshadowing into the future of some of the exciting stuff you'll be learning. Just to review the anatomy of the shoulder. So the function of the rotator cuff muscles as a whole, they work together to stabilize the shoulder. And additionally, each muscle is responsible for a certain movement of the arm. So we have an acronym, it's called SITS, S-I-T-S. Those stand for the four rotator cuff muscles of the shoulder, which are the supraspinatus, infraspinatus, teres minor, and subscapularis. I'm not going to go too much into all the origins and insertions, but I do want to bring up some important points that are going to be important to know in the context of what we talk about later. So the supraspinatus, as you can see here, it's this muscle right above here, and it sits within the supraspinous fossa of the scapula, which is, this is our bone, so this is the supra means above, so this is the supraspinous fossa. And this is also known in layman's term as your shoulder blade muscle. It attaches onto the greater tuberosity, which is right here. And just to orient you, this is a posterior view. So this is if you're looking from someone from the back towards the front, and this is our anterior view if you're looking from the front towards the back. And what is a tuberosity? It just means a prominence of the bone. So in the shoulder, your humerus bone, you have a greater tuberosity and a lesser tuberosity. So the supraspinatus attaches onto the greater tuberosity of the humerus. It's involved in complex motion, but if you had to boil it down to two really big ones, it's the adduction, which means moving the shoulder away from midline, and forward elevation. It also helps with stabilization of the shoulder joint as a whole. Our next muscle is going to be anteriorly located to the scapula. It's our subscapularis. This is in the subscapular fossa, anterior to the scapula, like I mentioned, and it inserts into the lesser tuberosity. This is mainly involved in internal rotation, adduction, so bringing the shoulder back to midline, and stabilization of the shoulder as well, mainly from being anteriorly displaced, or meaning kind of displacing forward towards the front of you rather than the back. So that's the role of the infraspinatus. Teres minor, our last rotator cuff muscle. This originates in the lateral border of the scapula and inserts into the greater tuberosity as well. This helps with external rotation, but it is a less dominant external rotator than the infraspinatus. Also helps with shoulder stabilization, mainly in maintaining alignment of the humeral head, and it also slightly assists with adduction, which is bringing your shoulder back towards your body. So I don't want to harp too much on the origins of insertions, but it is important to know in the context of what we're going to discuss, the tendon insertion, because it's going to be important when you're visualizing on ultrasound to know where those tendons insert and how to look for tears on an ultrasound in relation to anatomical positions. So that's just one quick review of the anatomy of the shoulder. I'm going to review some topics I'm going to talk about a lot as we go through adhesive capsulitis. So I wanted to get you familiar with some terminology. So you'll hear me say rotator cuff interval a lot. And what is a rotator cuff interval? You can visualize it on this image right here. And just to orient you again, this is an anterior view, and this is our supraspinatus, and this is our subscap. The rotator cuff interval is an anatomic space between the subscapularis and the supraspinatus. It is bound by the coracoid process, which is a prominent bone that's anterior located on your shoulder. And it also contains the superior glenohumeral ligament. So I know these names are a lot of words and it can get confusing, but the nice thing about bones and ligaments is they just are named for the things that they connect. So glenohumeral ligament, it connects the glenoid, which is here, to the humerus. So together, glenohumeral. So the naming of the ligaments themselves are kind of a cheat code for what bones they connect. So it does contain the superior glenohumeral ligament as well as the long head of the biceps tendon, which you can see running down here between these two tubercles, the greater tuberosity and the lesser tuberosity. You'll hear me also say a lot about axillary recess, and we'll talk about why that's important in a couple slides. The axillary recess, so in the glenohumeral ligament, we have three components you can see in this image. We have the superior GHL, the middle GHL, and the inferior GHL. These all connect the glenoid to the humerus. The inferior GHL has two bands. It's what's called an anterior and a posterior band. This axillary recess is located between those two bands of the IGHL. It's between the anterior and the posterior bands. The function of it is it's a space for synovial fluid. And synovial fluid, think of it as kind of like engine oil for your car. It lubricates the shoulder joint, it allows for smoother movements, and it also serves as a buffer zone. So if you fall on your shoulder or there's an impact to your shoulder in some way or shape or form, it serves as a buffer zone to absorb some of that shock. You'll also hear me talk a little bit about coracohumeral, which again, as the name suggests, connects the coracoid process to the humerus. That ligament is involved in stability. It's going to be your main limiter of external rotation, as well as superior translation of the humerus, or basically limiting your shoulder from being shrugged upwards excessively. It assists in maintaining position of the rotator cuff muscles as well. And we already talked about the glenohumeral ligament and its three parts. So I know it's a lot of anatomy right now. That's not the focus of it too much, but I just wanted to mention it because pathology, in the case of what we're discussing today, is a disruption of anatomical structures. Anatomy is a very foundational concept of medicine and is imperative to understand the anatomy when assessing for pathologies because they will guide us through our physical exam and diagnostic decision making. So as we continue this presentation, we're going to discuss a little bit more about pathologies of interest today and as they relate to this rotator cuff anatomy we went through. But as we go along, just from what I've told you about anatomy now, I want you to think to yourself, what may happen if there's a disruption in this anatomy? For example, if the joint capsule we just talked about or the axillary pouch, something goes wrong with it, or these ligaments get thickened due to inflammation, what do you think will be happening and what's the underlying potential pathologies? What if this tendon gets discontinued and there's a disruption in that structure? So I just want to keep that in the back of your mind. I think it's good to think this thing before they're presented, and we'll dive deeper in this as we go, but I just wanted to bring that to your attention. So now we'll talk a little bit more about pathology, and this is going to be the main chunk of what we're talking about today is adhesive capsulitis. So a seminal paper that was written on adhesive capsulitis, it was in 2011, but it is still referenced to this day in many research papers and many presentations that talk about adhesive capsulitis. And this was by an advisor, and the advisor was really changed the game and how adhesive capsulitis is viewed and how it's managed. And it's important to avoid the term, you might have heard the term frozen shoulder. It's important to avoid that in clinical settings. It may be okay to use it in layman's term to explain to them, but as clinicians and healthcare providers, it's very vague when you say frozen shoulder, because adhesive capsulitis itself is a very distinct pathological entity. It's important to use it in clinical practice as opposed to frozen shoulder, because frozen shoulder does not denote a specific pathological process. And as an advisor would characterize it, if you use the term frozen shoulder, that's just as vague as calling a gait abnormality a limp. It doesn't give you any information. So rather, adhesive capsulitis is used because it characterizes, as the name suggests, a chronic inflammation of the capsule subsynovial layer that results in or produces capsular thickening, fibrosis, and adherence of the actual capsule itself to the anatomic neck of the humerus. And if you're not familiar, I put a picture here just to show you where the anatomical neck, it sits on the humeral head, and then this is a surgical neck kind of away from the ball part of the humerus. So adhesive capsulitis, just quick clinical pearls, it's going to lead to pain. It's going to lead to mechanical restraint in all planes of motion. So that's forward elevation, external rotation, internal rotation. All the planes will be restricted in adhesive capsulitis, both actively and passively. So that's the key here. Active range of motion is having the patient do the motion on their own, versus passive range of motion is when you assist them as a physician or healthcare provider to complete the range of motion arc assisted. So that's the difference between active and passive. But here's the thing. Pain is not always present at all stages of adhesive capsulitis. So there are 4 stages. We'll talk about that more on the next slide. But I just want you to keep that in mind, that pain is not always present at all stages of adhesive capsulitis. The underlying cause of adhesive capsulitis today is still unknown, and that's what we term as idiopathic. We do know it's a gradual loss. We do know there's an inflammatory component from studies of Advisor and other subsequent papers showed from biopsy specimens, a clear progression of mononuclear inflammatory infiltrates and tumor growth factor beta, profibrotic cytokines, all that was shown in biopsy specimens. So we know it's inflammatory, but we don't know what the inciting cause of inflammation is. So that's why we label adhesive capsulitis as an idiopathic disease. So let's talk a little bit more about staging. So here, if you're unfamiliar, this on the right are images of arthroscopes, right? So an arthroscope is a small camera that has a light. It goes in a very small incision to the shoulder or any joint, and you're able to see into that camera. And if you need to, you're able to also do arthroscopic procedures to fix certain pathologies. So what happens in adhesive capsulitis? Like we mentioned, we have a thickened, tight glenohumeral joint capsule, and that space, this axillary fold we talked about earlier, in later stages gets obliterated. And that promotes, it starts from a chronic inflammatory process to eventually fusion of the actual glenoid and the glenohumeral ligaments together so that the normal anatomy is virtually unidentifiable. So there's 2 categories of staging. One is a general staging where you have your freezing, your frozen, your thawing stage. But with arthroscopy, you can get a little more specific in your staging. So when you go in an arthroscope, we'll have 4 stages. One is called stage 1. This is pre-adhesive. You can appreciate that on figure 2, image A. So here we see in stage 1, you have very fibrinous inflammatory synovitic reactions, but there is no adhesion formation yet. You could still see the structures and identify them. So here, this is going from the posterior pouch just to orient you. And this white line you see on top, that is your biceps tendon. This is your interval right here. So there's no adhesion yet. There's a lot of inflammation. You typically have pain, but patients still have full motion in stage 1 of adhesive capsulitis. And then stage 2, which is what we call the acute adhesive stage, the synovial proliferation increases, and you start to see here early adhesion form. You can see how all the structures are starting to begin to adhere to each other. And so figure 2, image B, is our stage 2 acute adhesive stage. Pain is becoming even more prominent now because this is the peak of the inflammatory process in adhesive capsulitis. So this is when patients will be in most pain, but range of motion is still pretty much preserved in stage 2. Now, when we get to stage 3, I want you to notice some difference here. You can see some red coloration in image B, but here we see most of that is gone now. So image 3 is where we see our maturation stage. And this is where we see less inflammation, less synovitis, and we start to get more towards a fibrotic stage. And this picture is just to appreciate what happens in stage 3. So at stage 3, your axillary recess, your axillary pouch, it's obliterated. So now the glenoid is pretty much fused to the actual humerus, and all those GHL ligaments are now fused to each other. And there's no pain as much as stages 1 and 2 with stage 3, but this is where motion really begins to be restricted. Patients can't lift their arm above their shoulder. They can't externally rotate as much. All planes of motion are going to be limited because there's now a physical barrier to that shoulder joint. And then stage 4 is when we get to the chronic stage. This is appreciated in image D, where adhesions are fully mature. Motion is very, very severely reduced. Pain is even at stage 4 absent. It only occurs when there's an excessive motion or motion that happened really quickly that exceeds the limitations of the shoulder joint, like putting on a coat really fast or raising your arm really quickly. That's the only thing that really elicits pain. So I want you to just think about that for a while we talk about diagnosis and presentation. If early on, if we say that the hallmark presentation of adhesive capsulitis is reduction of range of motion in all planes, but stages 1 and 2 have preserved range of motion, and catching this disease earlier has better outcomes, how do we then differentiate if it's stage 1 and 2 adhesive capsulitis if the hallmark feature is not there? So that we have to look at the history and we have to look at clinical presentation, and we're going to talk about one very sensitive test from a study done in 2018 that has almost 100% sensitivity for detecting early adhesive capsulitis. So just to really quickly go over risk factors, the 2 biggest risk factors to developing adhesive capsulitis is diabetes and thyroid disease. There are other risk factors, like if you have a previous history of shoulder or cervical surgery, fractures, radiation therapy, such as from breast cancer patients, sedentary lifestyles. It's more common in people who are aged 40 to 60. It affects females more than males. And surprisingly, it actually affects your non-dominant arm more than it does your dominant arm. So when a patient presents to you in your office, they'll have a very vague history, right? Humans as nature, we're connected. We like to associate an event to a symptom. So they'll come in, they're going to try to relate their symptoms to some minor injury that doesn't quite fit the bill. They'll say like, I picked up my son, or I was reaching for the top shelf, or something like that. And the things they're describing doesn't really match up with the clinical signs of symptoms. It doesn't make sense with physical exam findings. They often first notice their pain with a sudden movement. There's no specific point of tenderness on palpation. Sometimes the patients will report biceps tendon might be tender, and that's the part that goes right in between your greater two rod and typical. The biceps tendon goes in between that groove, so it's kind of like in the midline of your humerus. They might have some tenderness there. They might have some tenderness over the rotator interval, but typically inspections are unremarkable and no real tenderness palpation. Like I said in the beginning, if it's early stage, rotator cuff strength is usually normal. But if there's one thing to be cautious about, if the patient says, I'm having a lot of pain with overhead movement, that should point you away from adhesive capsulitis. Because A, adhesive capsulitis, they won't be able to get to that overhead movement as well. And B, there won't be as much pain with the actual movement itself. It's more pain getting to that point than it is the overhead movement. That's more indicative of a tear or some tendinitis of the actual muscle. Different pathology, we should think of something differently. For imaging and radiographs, they're typically normal, but it's important to get to eliminate other causes like arthritis or calcific tendinitis, which is basically like growth of calcium on the bone that leads to inflammation of the tendon, or some unrecognized shoulder dislocation. So MRIs and radiographs are more so for exclusion. They're not required for diagnosis. They're just helpful to find if there's any other underlying pathology, because there is something called secondary adhesive capsulitis, which occurs due to a rotator cuff tear or something that happened preceding the adhesive capsulitis, and you don't want to treat it the way you would normal adhesive capsulitis. You want to treat the underlying etiology. I know I'm talking a little fast. I want to try to get within that 45-minute time frame so we don't keep going everyone too fast. But if I'm going way too fast, please type in the chat and I will slow down a little bit. So for diagnosing, like I mentioned, stage 1 of the disease, it's very difficult because it's going to present to so many other pathologies. It's often confused for a rotator cuff tear. It could be confused for general arthritis. It could be confused for calcific tendinitis. There's so many diseases and signs and symptoms that are uniform across the shoulder pathologies that makes it very difficult to diagnose adhesive capsulitis, which is a problem because the best functional outcomes for treatment start if you treat it at stage 1 or 2. So overall, just a real quick summary. Data underlines the importance of early diagnosis to provide the patient with best outcome. That is from the FIDA et al. Paper on adhesive capsulitis. The earlier you're able to diagnose, the better the outcomes, which brings me to my next point. Highest sensitivity that we discovered in 2018 by Dr. Savoy was the inferior glide test. I'm going to show you a video of that on my next slide. Before I play this video, I just want to kind of preface what Dr. Felix Savoy did. So Dr. Felix Savoy, he's an orthopedic surgeon at Tulane University. I believe he was at one point the chair of the AAOS, and he'd done a study with 280 new shoulder patients that came to his clinic. They were independently examined both by him and by his residents, and of the 280 patients, 35 presented with a positive inferior glide test. And a positive test is basically if the patient is experiencing pain while you're doing this test. That is considered a positive test. The remaining 245 patients had a negative IGT. Of those 35 who had a positive IGT, all 35 of them went on to develop adhesive capsulitis. The remaining 245, they did have other shoulder pathologies, but none of them were adhesive capsulitis. So Dr. Felix Savoy's study revealed that there was almost 100% sensitivity for adhesive capsulitis with this IGT test. If there's anything you take away from today, take that away. Positive IGT equals early adhesive capsulitis. And when I play this video, it'll make sense why, and I'll kind of talk over it while you guys are watching the video. So let me just make sure this plays first. All right. So what are you testing here? The motion he's doing is he's testing the main structures of the coracohumeral ligament here. And mainly, in particular, if you really want to get down to which ligament he's testing, it's the inferior glenohumeral ligament and the two bands that compose it, the anterior and posterior band, because those are the two bands that are heavily involved early in adhesive capsulitis stage 1 and 2. So what he does here, he arms slightly abducted to 40 degrees, the elbows cupped, and he does a gentle inferior shift into those inferior glenohumeral ligaments. And by inducing that shift, he's pulling on the anterior and posterior bands with that pulling type movement. And if you are in stage 1 or 2 adhesive capsulitis, because those ligaments are inflamed, by pulling down and isolating those two ligaments, eliciting pain is very, very sensitive for an adhesive capsulitis diagnosis. So this is going to be a very important test in clinical practice in the future to catch adhesive capsulitis early on and direct your patient to the appropriate treatment for better functional outcomes. So just to kind of wrap up with some treatments, initial treatment, contrary to popular belief, it's not surgical. It's actually steroid injections. So if you look at the plethora of literature out there on adhesive capsulitis, the only thing that makes a difference is intra-articular corticosteroid injections based on the clinical evidence we have. Other modalities of treatment are anecdotal. They don't have clear, tangible evidence, but all the papers out there show that intra-articular steroid injections is the best first-line treatment for adhesive capsulitis, and you have to couple that with physical therapy. The goal of physical therapy is for gentle stretching. We don't want to push the patient too much. We're trying to relieve pain, not induce more. So the goal is to gradually regain motion with physical therapy and injections, not rapidly. And to get specific, if you really want to know where they're injecting it, that intra-articular injection, you're aiming to hit the posterior inferior glenohumeral ligament, right? So most surgeons will approach it posteriorly. They'll try to get that PIGHL, and while they're in there, they'll redirect the needle upwards to also hit the CHL. So they're kind of hitting two ligaments in one with one approach. And then also there's a study that was done in 2014 on a Cochrane database review. They looked at 32 different trials with over 1,800 patients, and steroid injections was definitely effective in decreasing pain on a visual analog scale and improving motion amongst the majority of patients. They also looked at seeing if manual therapy versus at-home therapy had any difference. There was no difference. One interesting find that they found was if you did aquatic home exercises, that had one of the highest modalities for positive patient-reported outcomes. So if your patient has access to some sort of aquatic therapy or a swimming pool, that's going to be the best physical therapy for them. And then oral steroids, subjective effectiveness, improving well-being. There's another systematic review looked at 25 different studies across 7 randomized controlled trials. 92% of those patients who had an intra-articular injections improved with those injections. And this is another interesting thing about they found about adhesive capsulitis from a systematic review. They call this a self-limiting disorder because no matter what you do, whether you give injections or medications or whatever it may be, regardless of treatment, within 2 to 5 years, all patients will resolve their symptoms. So your patient can come in the office, you can let them know this, and you'll say, hey, I can treat you today, or you can go home, and if you're still being bothered in 2 to 5 years, you're still stiff, come back, we'll do something else. 9 times out of 10, people will elect to do something right now. So that's just something you can tell to comfort your patients, but it's better. We don't want our patients to be in agony for 2 to 5 years, so we want to treat them now with the injections and physical therapy. Next line treatments. This is limited to people who are refractory. So if corticosteroids don't work, if PT doesn't work, nothing's going well. There are two surgical options we can do for adhesive capsulitis. One is outdated, still used very little today, and that is manipulation under anesthesia. Indications for that is failure to improve within 3 to 6 months of physical therapy, especially if you have been diagnosed with stage 3 or 4 adhesive capsulitis. However, you never, ever, ever, ever want to manipulate a diabetic patient. For reasons unknown, diabetic patients have a 50% failure rate if they undergo an MUA procedure. We don't know exactly why, but you're all but guaranteed to have 1 out of 2 patients always fail that procedure and have some even more serious complications afterwards. So never put a diabetic patient under manipulation under anesthesia. Also, we don't, it's contraindicated is if they just recovered from another surgery in the context of repairing a rotator cuff or repairing a slap tear or anything else that a tendon that was torn or fixed. Doing this MUA procedure has a very high risk of re-tear. There are also inherent risks of the procedure itself, not just contraindications. There's a 10% risk of fracture, 2% risk of plexopathy, and if you're not familiar with what plexopathy is, it's just a fancy way of saying the network of nerves, the plexus in the body, gets irritated and it can cause symptoms like pain, weakness, paralysis, stuff like that. There's 2% chance of that. Dislocation is very, very rare, less than a 1% chance, but if it does occur, it's a very devastating risk that comes with a whole nother downstream effects of stuff you have to take care of. As surgery progresses, though, now we have something which is the standard for surgical treatment for patients refractory to first-line care, and this is an arthroscopic release. So those same cameras we talked about earlier, where they go in and they look at the shoulder joint, you can also, through a minimally invasive procedure, actually cut some of those thickened ligaments and do what's called a capsular release to get a 360-degree release of that shoulder anatomy, that ball and socket joint, to kind of widen it and give it more space for it to move. So this is now the standard going forward if anyone does need surgery for adhesive capsulitis. It's minimally invasive. It's much, much lower risk than MUA. And while they're in there, some surgeons, this is a controversy, but some surgeons actually go in and do a biceps tenotomy while they're in there. And tenotomy is just a way of saying cut. So some surgeons believe that the biceps is another pain generator. If they go in there and they see some inflammation spread to the biceps, they'll actually cut some of that tendon as well. But if they see it's fine, they won't. So that's just surgeon preference. Just to give you a little bit insight into how the surgery is done, what they do is they call a superior to CHL release, and they go in a systematic fashion to get that 360-degree release. So they'll start superiorly at the top of the shoulder. They'll put the arthroscope in there. They'll clean off that rotator interval. They'll see if there's any thickened GHL ligaments in that area, and they'll kind of shave those down. They'll then go anterior release down to 5. And if you're unfamiliar with anterior release down to 5 means, it just means that they are going to cut and release the tight inflamed tissue of the shoulder capsule from the front to the anterior, and they're going to extend down inferiorly to the 5 o'clock position. So if the top of your shoulder was 12, then they would go down clockwise to the 5 o'clock position, and they'd shave in that orientation. And they keep on doing that from anterior, then they go posterior release and inferior, then they finally make their way back up to the corticofemoral ligament, which is located in the bursa itself, and that achieves a 360-degree release where you can cut those thickened and inflamed ligaments and kind of allow the shoulder joint have more space to move. This is good. This is good results for a surgical intervention. Post-op care, it's important to keep your patient immobilized. You want to have them at 90-degree abduction and external rotation, and you want to have the head of the bed elevated when they're sleeping to 30 degrees. You want to keep that arm abducted for 2 days post-op, and you want to have the patient continue sleeping in that position for 2 weeks. That's been shown to have the most optimal path to recovery. And contrary to what you might think, exercises and physical therapy actually begin day 1 post-op. Again, the goal here is gentle progression, and we don't want to rush into therapy, but you do want to start it the next day after surgery, and you want to continue that 3 times a day for 3 to 6 months, depending on the individual patient's characteristics. So that's about it for adhesive capsulitis. I'm not going to go as near in depth into rotator cuff tears because it's much more complex. I just want to give a couple clinical pearls to kind of give a segue into my proposed research project for what we're going to do in terms of these shoulder pathologies. So rotator cuff tears, it's very prevalent. It's a cause of shoulder pain disability. It imposes a significant healthcare burden because it's tricky sometimes to diagnose, and being accurate and having cost-effective diagnostic methods, they're so crucial for guiding treatment. And actually now that I think we all have ultrasounds that Toro gave us, and I truly believe ultrasound is going to change the way diagnostic care is done in the future, especially at an orthopedic level. Because before a couple of years ago, MRI was the standard for diagnosing rotator cuff tears. But now that paradigm is shifting. We are actually transitioning more to having in-office ultrasounds become the gold standard for determining rotator cuff tears. It's very sensitive, it's very specific, and the more surgeons or primary care providers have experience with ultrasound, the better they are able to diagnose specifically supraspinatus tear, which again is this muscle above the suprascapular fossa. And they also can diagnose subscapularis tears very well, which sits anteriorly here onto the lesser tuberosity. Ultrasound, more affordable, cost effective, significantly lower reimbursement rates, and reduced patient wait times. So you're talking about a modality that increases patient satisfaction, decreases patient costs, and increases the amount of decreases the amount of time from presentation to diagnosis. So in a nutshell, there's two types of rotator cuff tears. There's traumatic, which is a result of an injury, a fall, or excessive force, etc. And there's atraumatic, which is age-related. So if you were to take 10 people off the street at random who are over the age of 60, 6 to 7 of those people would have rotator cuff tears in their shoulder, and about 4 to 5 of them wouldn't even know it. So that's what I mean when atraumatic rotator cuff tears is a part of the natural aging-related process. And it's considered part of the normal parts of aging. So as age increases, the incidence of tears and enlargement increases with it, and it can also lead to increased risk for arthritic changes and for your actual humerus, which is the head of your arm bone, basically, to migrate in different directions because those tendons are no longer providing stability. Early surgical intervention is better for traumatic tears, but actually non-operative management is better for atraumatic tears through physical therapy, steroid injections. Sometimes they do like what's called viscosupplementation, where they take autocrine producing hyaluronic acid and increases your body's natural ability to heal itself. That's still anecdotal research, but the two main ones is physical therapy and injections. Excuse me. So that's about it for rotator cuffs and adhesive capsulitis. But I hope that you've been able to see how difficult it is to diagnose these treatments in non-orthopedic settings. So someone who's an orthopedic surgeon, they've seen this time and time again. They're aware of these tests. They know how to diagnose it. But the patients coming in with these problems don't always go to an orthopedic surgeon first. More often than not, they are going to primary care physicians. And to that effect, that leads me into my next slide, which is my research project proposal. And Jack will talk a little bit more about signups, because at the Orthopedic Surgery Journal Club, we want to also make this something beneficial, not just for us as committee members, but for you guys as participants. We want to have throughout the year open up research projects for all of you guys to sign up for based on interest, where we do different types of literature reviews from narratives to scoping, systematic, and even if we want to, meta-analysis. So we want you guys to get something out of this. I'll let Jack talk about that a little bit more, but I'll just present what I'm proposing for my first research project. So the title of this project that I'm going to be doing over the next 6 months is called From Clinic to Referral, Practical Cost-Aware Guidelines for Evaluating Shoulder Pain in Primary Care. So where does this problem stem from? It stems from that most shoulder pain starts in primary care. Patients are seen by primary care physicians first, but there are variable workups. There's no definitive guideline for evaluating the plethora of common shoulder conditions in a primary care setting. They only exist in orthopedic specialty care settings. And you can imagine how that might lead to higher costs, delays in treatment and diagnosis, and inconsistent referrals. So the aim of this project is to build a resource stewardship where we can develop a first contact algorithm for atraumatic adult shoulder pain from the lens of primary care physicians. The scope of this will focus on 3 of the main diseases, which is rotator cuff disease that can be either adhesive capsulitis or a tear, adhesive capsulitis itself, and subacromial pain, which is known as SAPS, which has a couple of subsections to that. And also include any red flags where if a primary care physician sees this, we have to send you to X place or X physician. We're going to exclude traumatic because I think traumatic is a very case-to-case basis. But what are we hoping to get from this research project? We want to have a narrative review, and we want to come with a 1-page diagnostic and imaging algorithm that is clinic-ready to be printed and provided to primary care clinics. And we have to want to include in that referral triggers by condition, provide patient handouts, because I truly believe that in any healthcare setting, it should be a shared decision-making, and it should ultimately be the patient's decision. And we want to include them with what might be complex science in a way that's digestible for them to understand and share in that decision-making process. So what's the ask from all of you today? Jack's going to talk about it, but we're going to open signups for students interested in joining our first Orthopedic Surgery Journal Club research team. Areas you can assist with, we're going to have imaging section, exam evidence, health economic inserts, and many more. We're going to have, hopefully, Dr. Taylor or Dr. Tiford be one of the faculty mentors for this project. And we'll also partner with the librarians here on campus to help us with covenants and database search. So it'll be those two from a faculty perspective, and then there'll be student signups based on the form. And with that, I want to thank you guys for listening. I hope I didn't talk too much or too fast. I hope that was informative. I'm very much looking forward to the feedback from Dr. Taylor and Dr. Tieford. And thank you guys so much for joining us in our first Journal Club meeting. And with that, I will pass it over to Jack.
Yeah, round of applause really quickly. Yeah, Target, we can just scoot me forward one slide. I'll just talk really quickly because I want to stick to or two slides, I guess. Um, yeah, pretty straightforward. You want to be able to present like Tarek just did. Let's let's help carve out a path for that to be able to happen for everybody. So some of the ideas that we've talked about, and I want to again thank Tarek and Ian and Arnold and a lot of other people who've been and Dr. Taylor and Tifa obviously who've been helpful in this process so far. We want to try and carve out opportunities for everybody, including ourselves, and stuff that we wish we had had in first year as well too. So publications. The idea is going to be every single presentation we do absolutely has the potential to become a review paper. I mean, you saw the depth that Tarek just went into. So presenters and in the future co-presenters who are also on the main presentation will get to pick a topic. And then, of course, they'll be able to kind of figure out what space they want to fill in and have those first authorship opportunities. We want to include another thing that would have been really, really helpful to get our hands on first year, which is actual research training. So we've already secured a partnership with the faculty librarians to teach and assist with covenants, search strategies, keywords, review methods, and fast tracking your group into, real meaningful research. We also want to set up a priority for participation. So the people who obviously put together the presentation will be the people who kind of determine the direction, and they'll be the first authors and seconds, and they'll figure that out. But for those of you guys who showed up and listened to all of us the entire time, I mean, you're certainly next in line. You're now well informed on where this is going and the directionality. So we'd love to be able to have you participate. And then lastly, we plan on putting out all of these videos for reference in general, but to also have anybody who wasn't able to make it to this meeting, unfortunately, but can manage to watch it in the next couple of days here, actually be able to participate as well too, in case, again, a conflict just came up. So that's inevitably what the research is going to look like. The QR code down at the bottom that I'm pretty sure works. If not, I'll send it out in an email. Don't worry. That has a student interest form. That'll give us an idea of what you're interested in, the role you might want to participate in. And again, no pressure in the slightest. Our goal is to be doing this every single month and to, again, come up with a topic you might be more interested if adhesive capsulitis or shoulder pathology is not specifically what you're interested in. Another couple things the other big thing I want to talk about is next actual club meeting, we should have our IRB approved study where I can get you in a pre and a post survey. It should be about like 3 to 5 minutes each to track growth in orthopedic knowledge and clinical language, your comfortability with orthopedics in general. I will offer raffle entries every time you participate. So both gift cards for every single session. And if you come to a bunch of sessions, even if you don't decide to present or publish any research with us, that's totally fine. But if you keep showing up and learning orthopedics with us, I'd love for you to have the opportunity to win a more longitudinal prize that we'll hand out in May for a couple people, obviously. So bottom line is show up, learn orthopedics, get published, win prizes. Should be straightforward, should be a really good time, and should be a really good opportunity for everybody who's interested in orthopedics or really just this in general. Yeah, I figured the QR code wasn't going to work. I'll just send out an email after this anyway. But either way, thank you guys so much. I want to hand it probably off back to Tiford and Taylor, since this original idea was to be able to get some feedback on both how the presentation went, if the direction of the paper seems about right. So yeah, whoever wants to take it over from here. But I really appreciate everybody for showing up to this first meeting. This has been a wild success.